Hi, I'm Jeff Klein, editor of RadioGraphics, and today I am pleased to have with us Dr. Velayudhan from SUNY Downstate and Dr. Vamsi Kunam, also from the State University of New York Downstate Medical Center in Brooklyn, New York, who are the authors of one of our featured papers in the current July-August 2018 issue of RadioGraphics, which is entitled Incomplete Cord Syndromes, Clinical and Imaging Review. Drs. Velayudhan and Kunam, welcome to our podcast.
Thank you. Thank you.
Dr. Kunam, we'll start with you. Your paper begins with a very nicely illustrated review of the normal spinal cord anatomy, focusing on the dorsal columns, lateral corticospinal tract, spinal thalamic tract, and the blood supply to the cord. Can you review for us what is meant by incomplete as compared to complete cord syndromes? And then we'll look at figure 1, in which you'll discuss the pertinent anatomy that's related to this figure.
Okay. So the spinal cord serves as a highway for information to travel between the brain and the peripheral nervous system. Transmission of information is accomplished by highly specialized afferent, efferent pathways, relay neurons, and their interconnections. Afferent pathways carry sensory information from the periphery to the brain. Efferent pathways carry predominantly motor information from the brain to the periphery. Interruption of these pathways results in the development of spinal cord syndromes, classified neurologically as incomplete or complete. Complete cord syndrome is caused by a lesion involving a whole spinal cord segment and will produce complete motor, sensory, and autonomic dysfunction below the level of the lesion. It's caused by lesions such as transection, complete cord transection secondary to trauma, severe cord compression by a tumor or epidural abscess, or an acute inflammatory process involving the whole cord such as transverse myelitis. Incomplete cord syndromes are caused by lesions involving part of the spinal cord segment and will produce a combination of various motor, sensory, and autonomic dysfunction either bilaterally or unilaterally based on the location of the lesion. It doesn't have complete deficit just like complete cord syndromes. So figure 1A is an illustration that shows axial cross-section of thoracic cord demonstrating central H or butterfly-shaped gray matter and peripheral white matter. Central gray matter has a dorsal or posterior horn highlighted in blue that's involved in sensory processing. Lateral horn highlighted in yellow containing interneurons and autonomic nuclei. And ventral or anterior horn highlighted in pink color that contains motor neurons. The orientation of this image on this graphic is traditional textbook anatomic description of spinal cord anatomy, depicting dorsal columns on the top and the anterior ventral horns on below. In real-life imaging of the spinal cord, dorsal columns are seen along the posterior aspect of the cord, while ventral horns are seen in the anterior cord. As I discussed the other images, I'll just let you. That's the reason I'm telling you in advance. Located in the periphery are white matter tracts, dorsal columns labeled as DC, lateral corticospinal tract labeled as CST, spinothalamic tract labeled as STT. Note the somatotropic organization of fibers in the corticospinal tract and spinothalamic tract from medial to lateral, thoracic, lumbar, and sacral. Note 10% of corticospinal tract fibers do not decussate and continue epilaterally as anterior corticospinal tract labeled with black spot. Arrows point to dorsolateral sulci where dorsal nerve roots enter, and curved arrows point to ventrolateral sulci where ventral nerve roots enter.
Great. Thank you so much. After this review and introduction, you review the 6 incomplete cord syndromes, which begin with dorsal cord syndrome. Can you describe this syndrome? And we'll take a look at figure 7, which I think illustrates sort of the classic MR findings that are seen in this particular condition.
Sure. So a lesion in the posterior 1/3 of the spinal cord that primarily involves posterior columns results in dorsal cord syndrome and presents with loss of fine touch, vibration sense, and proprioception. Patients present with sensory ataxia, usually with a history of dizziness, unsteady gait, and frequent falls, especially during activities in the dark or when they close their eyes. Normal balance requires 3 sensory inputs: vestibular, visual, and proprioception or joint position. Dark environments and activities involving closed eyes, such as showering, remove visual input, and lack of proprioception from dorsal column involvement. That's loss of 2 out of 3 sensory inputs required to maintain normal balance and results in patient losing his balance. On clinical exam, patient presents with a positive Romberg sign, which is loss of balance or swaying if you ask the patient to stand erect with eyes closed. Large lesions can also affect the lateral corticospinal tract and autonomic tracts of the sacral cord. Involvement of corticospinal tract causes weakness and spasticity. Involvement of autonomic centers causes bowel and or bladder incontinence, erectile dysfunction, and orthostatic hypotension. So we have a figure, classic figure 7, which shows dorsal cord syndrome features. Figure 7 shows subacute combined degeneration in a 42-year-old man on a vegan diet for the last 2 years. History of frequent falls. Most recent fall was while showering. This is an axial T2-weighted MR image of the spinal cord. Arrows point to hyperintense signal in the dorsal columns in the classic inverted V configuration. Just to remind you again, the orientation of the cord is opposite to the typical anatomic description shown in above graphic 1A. Dorsal columns are in the posterior spinal cord. If you're interested in how dorsal columns are the first fibers involved in subacute combined degeneration, I can discuss the pathophysiology. It's pretty interesting if you want to describe it. Can I describe it? Or?
Sure.
Axons in dorsal columns that carry proprioception, fine touch, and vibration are large diameter A-alpha type 1A fibers. These are the largest diameter, highly myelinated axons in the spinal cord. Normal myelin production requires B12. Vegan diet, they have B12 deficiency, and B12 deficiency results in demyelination of these large, highly myelinated fibers first, followed by other small fibers in the age wherever CST or autonomic nuclei. That's the reason they start with these symptoms. That's the reason they have this classic V-shaped configuration in the back. There's a columns that get demyelinated.
See, very interesting. Thank you for that. So Dr. Velayudhan, moving on to the ventral cord syndrome, you mentioned this is the most often associated with spinal cord ischemia or infarction related to cord supplied by the anterior spinal artery. Can you describe the clinical conditions that are associated with this syndrome? And we'll look at figure 12 as an example of this.
Sure. So just for some basic background information, any process or lesion that affects the anterior 2/3 of your spinal cord that spares the dorsal columns is going to give you a ventral cord syndrome. That could be from a compressive lesion, say a disc herniation, or if you have a fracture fragment from a burst fracture with direct repulsion impinging on the ventral cord, that can give you ventral cord syndrome. If you have an intrinsic lower cord lesion, such as if you have multiple sclerosis and you have an MS plaque within the anterior cord, that can give you ventral cord syndrome. And as you alluded to, the most common cause or the most common scenario for having a ventral cord syndrome is going to be when you have cord ischemia or cord infarction due to involvement of the anterior spinal artery that preferentially supplies the ventral cord. And to answer your question, what things can give you cord ischemia or cord infarctions, there's a very broad differential for that. It's going to vary depending on the age group. So for children, most commonly you're going to see it in kids that have hypoperfusion or hypovolemia, say in a trauma situation, or maybe if they have a cardiac malformation. For adults, the differential for those for cord infarctions is going to be a little bit different. They're going to have infarcts most commonly related to pathology involving the aorta or the branch vessel of the aorta. That can include atherosclerosis. It can include if you have an aortic dissection or if you have an aneurysm. And then also classically, people that have aortic surgery, they can get iatrogenic ischemia from the aortic surgery, and less commonly, people that have CABG surgeries can have the same kind of issue with cord ischemia related to lack of adequate blood supply. You can also less commonly have cord ischemia related to cardiac embolism, hypercoagulable states. Patients can, if they have a large disc herniation or some other process with mass effect, can have direct compression of their anterospinal artery as well. And you can also get venous infarcts of the cord due to venous hypertension and ischemia. The classic things that will give you a venous infarction of the cord are going to be hypercoagulable states. If you have a spinal vascular malformation, say spinal dural AV fistula, and then even spinal infections, if they spread to the epidural space, can give you thrombophlebitis that can lead to venous hypertension and cord ischemia as well. So there's a really broad differential. One important thing to keep in mind is that in up to a third or maybe half of cases, despite having a extensive workup, and the radiology department doing all kinds of different tests to look for an etiology for the cord infarct, and up to a third or half of cases there, the etiology remains unclear.
Great, thank you for that.
Sure. I'm just going to describe Figure 12 now.
Yes.
So Figure 12 is an axial T2-weighted MR image through the thoracic spine. You can see here that there's an abnormal hyperintense siddle within the ventral aspect of the cord with a appearance resembling owl's eyes or snake eyes. That appearance is due to preferential involvement of the anterior horn motor neurons. The ventral part of the cord has its main blood supply from the anterior spinal artery, which is a single artery without good collateral blood supply. The periphery of the cord and dorsal part of the cord are darker on this T2-weighted image because they're relatively spared because they have a better collateral blood supply. The periphery of the cord has a rich peel plexus that supplies it, and the dorsal aspect of the cord has paired right and left posterior spinal arteries. So those are less likely to be affected by ischemia. They're going to appear darker, and that's going to contribute to that owl's eye appearance.
Great. Well, thank you for that. Dr. Kunam, we'll go back to you for this next part. Central cord syndrome is the most common of these incomplete syndromes and is most often secondary to trauma, in particular hyperextension injuries in elderly patients whose spinal canals are already compromised by cervical spondylosis. Let's look at Figure 13, which illustrates the situation, and then Figure 14 that I think shows a nice example of this condition in an older patient on MR.
Yep. Yeah, I just said trauma is the most common cause in elderly patients, and the trauma can be very trivial, and most patients might not even remember a small fall, mild hit somewhere. It would not be like a major trauma like a motor vehicle accident or a big fall. Trivial trauma also, because the reason is card gets pinched between. This illustration clearly shows that. Figure 13 shows hyperextension injury in older patients with central cord syndrome due to underlying cervical spondylosis. Arrows point to anterior disc osteophyte complexes, and the arrowheads point to posterior buckling ligamentum flavum. See the pinching of spinal cord between anterior disc osteophyte complexes and the posterior ligamentum flavum buckling, and see the central contusion in the center of the cord. Figure 14 is a classic example of the above graphic. It shows cervical spondylosis with cervical stenosis in a 73-year-old man presenting with burning sensation and weakness in the upper extremities 2 years after a fall. Sagittal T2-weighted MR image shows severe cervical spondylotic changes. Arrows point to disc osteophyte complex. Arrowheads point to ligamentum flavum buckling. White arrowheads point to buccal ligamentum flavum. Black arrowhead points to mild increased signal in the cord secondary to myelomalacia.
Great. Well, thank you for that example. Dr. Velayudhan, we'll go back to you. After a discussion of Brown-Séquard syndrome, you review the Conus Medullaris syndrome, which most often results from disc herniation. Figure 27 shows us a case on CT and MR. Can you take us through this?
Yeah, sure. So the conus medullaris is the distal end of the spinal cord, which usually terminates around T12 or L1. And for that reason, lesions that cause conus medullaris syndrome are usually going to be at one of those two levels typically. So here we have a sagittal CT image and a sagittal T2-weighted MR image. The sagittal CT image demonstrates a burst fracture of the T12 vertebral body, just shown by the arrow. The arrowhead on that image points to bony retropulsion of the posterior cortex of T12 into the spinal canal, resulting in severe spinal canal stenosis. The T2-weighted sagittal MR image demonstrates the burst fracture with diffuse marrow edema. The arrow points to retropulsion of the posterior cortex of T12, and the arrowhead points to the conus medullaris, which is compressed and demonstrates high T2 signal due to cord edema.
Right. Terrific. Thank you. So finally, we have the Cauda Equina syndrome, which, as you mentioned in the paper, is not a true incomplete cord syndrome, but does have symptoms that overlap significantly with those of the conus medullaris syndrome. Again, this syndrome usually results from disc herniation, but is also seen in a variety of other conditions, including lumbar spinal stenosis, arachnoiditis, and some primary tumors of the nerve roots that develop in this region. MR is clearly the best way to evaluate these patients. Can we review figure 31, which shows a patient with spinal stenosis who presents with this particular syndrome?
These images are sagittal T2-weighted and axial T2-weighted MR images. The arrowheads demonstrate disc bulges or herniations impressing upon the ventral aspect of the fecal sac. These small arrows point to ligamentum flavum buckling or infolding, compressing the dorsal aspect of the fecal sac, creating an hourglass appearance. And the white arrows anteriorly show a redundant or serpiginous appearance with Cauda equina. The axial T2-weighted image below demonstrates a trefoil or tri-leaf appearance of the spinal canal and fecal sac related to degenerative disc disease with buckling of the ligamentum flavum posteriorly. And that's an appearance you can classically see with moderate or severe spinal canal stenosis, especially within the lumbar spine.
Thanks, Vinod. Dr. Kunam, for our viewers, Table 1 in the paper provides a nice review of these syndromes, including the involved tracts, the location of the lesion that's responsible for each syndrome, and the common etiologies that are associated with each syndrome. Could you just sort of summarize what the table demonstrates?
So this table summarizes the features of different incomplete cord syndromes. Information provided about each syndrome includes the tract involved, lesion location, common causes, and the typical clinical presentation associated with the syndrome. Radiologists and clinicians can use this as a reference to correlate clinical symptoms and imaging findings to ensure that the area of interest is appropriately imaged and evaluated on cross-sectional imaging.
Great, thank you. Well, so Drs. Velayudhan and Kunam, I want to thank you for taking the time today to discuss your paper on the imaging of incomplete cord syndromes, which again can be found in the current July 2018 issue of RadioGraphics. Doctors, thank you for your time today.
Thanks a lot, Dr. Klein.